consistently found an increase in PTH for all the 4 occasions and even after surgery. So the possibility of paraneoplastic syndrome is less likely or not possible in this patient.
So can I have one more comment? We have classified acute recurrent pancreatitis. Now, is the term acute recurrent idiopathic pancreatitis still existing? Because after you've investigated, and in this case you were fortunate that you could get a case of underlying etiology as possibly hyperparathyroidism. But there may be some cases in which there is no cause certain in spite of everything which has been done, and the patient continues to come back to us with recurrent acute pancreatitis. So a term which has been coined for these patients is recurrent acute idiopathic pancreatitis, and there's a series in which some of these patients end up in total pancreatectomy to give a relief. Any thought on any question, comments on that?
Yes, sir. In the case series that I presented, the chances of idiopathic pancreatitis is as high as 32% after the first episode. So if the patient persists with pancreatitis and we do not find any other etiology, then we might go forward with the same. But in our patient, we could find the etiology, and hence we have gone for the parathyroid surgery in this patient.
So quoted a series from your center of 50 odd patients, and you said almost 50% you could find some cause. So can you give a little more details as to what was the cause in these patients? Because in our experience, the majority of the time when you investigate these patients, either you do not find a cause or you find underlying chronic pancreatitis.
Yes, sir. Actually, almost the 50% that we got in that series, almost out of that, 32% had underlying chronic pancreatitis. So almost 16 of the 51 patients had chronic pancreatitis. In the remaining, we could find gallstone, microlithiasis, and CBD stone in the remaining around 18% of these patients.
Anurag, what will be your first investigations after an attack of pancreatitis? Will it be MRCP or will it be EUS?
So we at our center are doing MRCP first, and of course there is no definite reason to do so. It's just our department. We do it after the first attack of idiopathic pancreatitis. We don't wait for the second attack for it to be called a recurrent acute and then do it. And if the MRCP does not reveal anything, does not give us any positivity, we always do an EUS after the first attack. And why MRCP first is it's a non-invasive, more comfortable to the patient, and that's why. What would be your take on it, sir?
I agree with you that we also would do MRCP first, though we know that MRCP can miss a number of chronic pancreatitis, where you don't say the parenchymal changes on MRCP. So if you do EUS in them, then a significant proportion of them, where the MRCP is normal, may have actually changes of chronic pancreatitis on the EUS. Okay, so should we move on to the second?
Yeah. Yes, sir.
Hello. Am I audible?
Yes, you are audible.
Yeah. Good evening, everyone. At the onset, I will like to thank NB Goenka sir and my consultants for providing me with this opportunity of presenting a case in this national platform. So the second case which we will be discussing, is of a patient with recurrent cholestasis since last 8 years. We have a 43-year-old female who is a known case of CKD and presented complaints of recurrent episodes of itching since last 8 years and yellowish discoloration of eyes and urine since last 1 month. Itching started 8 years back. It was generalized, mild, more during night time, and it was very mild and did not affect her daily routine and would only occasionally disturb her sleep. This was not associated with fever, skin eruptions, jaundice, or ingestion of any new drug. It used to get relieved with topical lotion or oral medication prescribed to her by her nephrologist within a few weeks. However, The itching recurred every year, mostly during the winter season. The itching episodes were similar in nature to her previous episode, and the itching used to get aggravated during her menstrual periods. The itching resolves within week either spontaneously or with topical lotion or oral medication. And the longest episodes of itching, which she described, was for 2 months. This relapse was not associated with a decrease in her urine output or dryness of scaly skin. Meanwhile, during a routine follow-up to a nephrologist around 7 years back, on routine investigations, she was detected to have raised transaminases. She was referred to a gastroenterologist and investigated. She had some blood investigation, sonography abdomen, and a upper GI endoscopy, which was told to be normal. She was prescribed some medication and was told to have fatty changes in her liver. On subsequent visits, the transaminases level fluctuated from within a normal range to a maximum of about 100 national unit per liter, according to her husband. For the last 2 years, she was completely asymptomatic. There were no itching episodes, and she was told to have normal LFTs on follow up. Her latest relapse was in October this year, which was a bit unusual in that it was earlier than her usual yearly relapses. The itching was much severe in intensity, which disturbed her daily routine activity and sleep. And for the very first time, itching was associated with yellowish discoloration of eyes and urine, but it was not associated with pain, abdomen, fever, prodromal symptoms, abdominal distension, pedal edema, altered sensorium, hematemesis, melena, or cola colored urine. She consulted a gastroenterologist for her current relapse and underwent some blood tests, a sonography abdomen, and an MRI abdomen. She was given oral steroids and UDCA. She had significant relief in itching within days of starting treatment, and jaundice resolved within 7 to 10 days. So she stopped medication after 2 weeks and skipped her routine follow-up, following which her itching recurred after a few days of stopping the medication and was referred to a center. There was no history of awareness of any abdominal lump, abdominal surgery, clay-colored stool, fatigue, diarrhea or blood in stool, anemia or blood transfusion, joint pain, oral ulcers, Raynaud's phenomena, dysphagia, dryness of mouth or eyes, night blindness. There was no history of suggestive any malabsorption. There was no history of ataxia, easy bruisability, no history of OCP or altered medication intake, no history of tattooing or high-risk sexual behavior, no history of cholestasis during pregnancy or jaundice in infancy. There was no history of weight loss or decreased appetite. There was no history of diabetes, hypertension, tuberculosis, hypo or hyperthyroidism, or any other chronic illness except the chronic kidney disease. Past history: in 2011, she suffered from urosepsis and stage 3 AKI, which required few sessions of hemodialysis, and subsequently she developed CKD. Since then, she is under regular follow-up of her nephrologist, and her creatine remains around 2 milligram per deciliter. She is a non-smoker. There is no history of alcohol intake, and she has regular bowel and bladder habits. She consumes some oral drugs which are prescribed by her nephrologist. She has history of jaundice in her brother, but it started only after he started consuming excessive amounts of alcohol for last many years. There is no history of jaundice in her parents or her children. So to summarize, we have a 43-year-old female who is a known case of CKD who presented to our center with complaints of recurrent cholestasis since last 8 years and recent onset of jaundice along with increase in severity of her pruritus since last 1 month without any other signs of hepatic recompensation or of cholangitis. So my syndromic diagnosis would be cholestatic jaundice, intrahepatic with recurrent relapsing episodes. My differentials would be benign recurrent intrahepatic cholestasis, a cholestatic autoimmune hepatitis, overlap syndrome, PSC with autoimmune hepatitis, classical primary sclerosing cholangitis, and very rare possibility of idiopathic adulthood ductopenia or primary biliary cholangitis. On examination, her vitals was stable. She was afebrile. General physical examination was unremarkable, except for some scratch marks on her abdomen and legs. There was no icterus, shiny nails, or stigmata of CLD. Her BMI and waist hip ratio was normal. On per abdominal examination, she did not have any hepatosplenomegaly or shifting dullness. So my differentials would remain the same. On reviewing her previous records, we can see that her transaminases used to fluctuate from a normal level to about around 120, 130. But during her recent relapse, they shoot up to around 500 units. Alkaline phosphatase has been done previously and it was raised in all three occasions and it was 378 in her current relapse. Bilirubin was normal in 2012 and 2017, but in this relapse it was 5.8 with a direct fraction of 4. GT was also raised previously and also during this episode. Hemoglobin platelet ESR in INR was normal. Creatine was between 2.5 and 2.8 milligram per deciliter for all these years. HIV was negative, X-ray was normal, and a colonoscopy done outside recently was normal. Her CLD workup showed she was negative for HBs antigen and HCV antibody. She was also negative for HCV RNA and total core antibody. Autoimmune workup, ANA, asthma, LKM, AMA, SLA were negative. Copper, ceruloplasmin, and ferritin was normal. Her previous sonography showed normal liver parenchyma, normal portal vein diameter. There was no splenomegaly or ascites. Liver stiffness done a few months back was 5 kilopascal, and upper GI endoscopy showed no varix. On reviewing her drugs, she was given vitamin E and metformin in the past, but only for a few months, and she has stopped these medications since several years. UDCA was given sparingly and for short periods of time, probably for her itching. Her current medication includes calcium, vitamin D, and iron supplementation, along with sodium bicarbonate tablet. While reviewing a drug history in such patient, we should be aware of all these exhaustive list of medication which can cause intrahepatic cholestasis and vanishing bile duct-like syndrome. And we made sure that she hadn't received these medications in past 7 years. This is her latest LFT, which shows that during the relapse, the OTPT was around 500, alphos was 378, so which gives us an R factor of 3.9, which suggests a mixed hepatocellular and cholestatic liver injury. Bilirubin was 5.8 with a direct fraction of 4, albumin was normal, globulin was normal, and GGT was 354. Her serology for hepatitis A, E, CMV, and HSV were normal in this episode. She was given UDCA and betamethasone tablet, and within 8 days, her transaminases decreased, alphos decreased, and bilirubin halved. And in November, when she presented to us, transaminases and alphos were mildly elevated, and bilirubin was normal. Her sonography abdomen done in October showed a GB sludge, a normal CBD, liver was normal size and eco texture. There was no IHBRD. Pancreas, spleen, portal vein was normal. There was no ascites, and she had bilateral small kidneys with loss of CMD. This is a MRCP images. I would like to apologize for the poor quality of the films because they were done outside at some other center, and I could arrange these films only on WhatsApp, so they might not be visible very clearly. I would like to apologize for that. And when he reviewed her MRCP images at our center, a radiologist was of the opinion that there was some pruning at the level of intrahepatic duct. However, the MRCP reported outside was suggestive of some calcified sludge in the gallbladder. CBD was 7 mm with abrupt tapering at lower end with possibility of stricture or spasm of ampulla, but there was no obvious mass region or calculus, and pancreas and pancreatic duct were normal. US was done at our center, showed a normal CBD with a normal lumen. There was no lesion inside the CBD. CBD measured 5.4 mm. The gallbladder did not show any intraluminal content. And when CBD was traced at lower end, it was normal, and pancreas and pancreatic duct was also normal. When we did an ERCP after selective CBD cannulation, after contrast injection, we could see that there was decreased arborization of peripheral ducts, which showed a pruning-like appearance of intrahepatic duct. This is a pictorial representation of how a prune tree looks like, and the possible differentials for a prune tree appearance are PSC, any etiology which causes advanced cirrhosis, and it has also been reported in sarcoid cholangiopathies. So this was her plan for this particular patient, but unfortunately, she refused for further investigations, and we couldn't reach to a definitive diagnosis. So what we intend to discuss further are various differentials which could be possible in our patient. This table highlights the various differences between an intra and extrahepatic cholestasis. In intrahepatic, itching is much more severe. Jaundice occurs either simultaneously or a few days after itching. There's no pain, fever, palpable gallbladder, or history of surgery in intrahepatic cholestasis, which are suggestive of an extrahepatic cause. In intrahepatic, we may find a family history and stigmata of cirrhosis. Also, transaminases rise to a much greater level in intrahepatic as compared to extrahepatic. So, in our patient, she had an 8-year duration of illness. She had a pretty benign course with frequent relapses. She had significant itching, and jaundice in this relapse occurred after appearance of itching. She had no pain, fever, palpable gallbladder, or history of surgery. Her transaminases were raised, and also the imaging was supportive of an intrahepatic cause. So, if we assimilate the clinical data which we have till now, we have a patient who is having recurrent episodes of intrahepatic cholestasis since 8 years. There's history of spontaneous remission of fluctuation. She has a recent episode of cholestatic hepatitis. However, there is no evidence of cirrhosis. There is no stricturing of extrahepatic duct. There is possible involvement of intrahepatic duct due to the proved reappearance in ERCP, and she was negative for conventional autoantibodies in AMA. This is a table which highlights the various different causes of intrahepatic cholestasis, which can include chronic cholestatic syndromes like PBC, PSC, and idiopathic adulthood ductopenia. Conditions with specific etiology like drug-induced cholestatic variety of viral, autoimmune, or alcoholic hepatitis, ischemic bile duct damage, infectious cholangitis, rejection of transplant liver, or it could be part of systemic condition like sarcoidosis, cystic fibrosis, graft versus host disease, and cholestasis associated with malignancy. When we extrapolate our clinical data to this table, the following we came up with the following differentials. Firstly, an autoimmune liver disease, which could be a PSC with AIH overlap. Classical primary sclerosing cholangitis could be a sarcoid cholangiopathy, or it could also be a IgG4 related sclerosing cholangitis, and a very rare possibility of idiopathic adulthood neutropenia. So, why overlap? Because a patient seems to have features of both an autoimmune hepatitis-like illness and also a PSC-like illness. Features suggestive of AIH are transaminases of more than 10 times. She had spontaneous remissions in the past, and she has a long subclinical course with only minimal increase of in liver enzyme, which is known in AIH. She had a drastic response to steroid, and though she was negative for conventional autoantibodies, 20% patients may not have these auto antibodies. Features suggestive of PSCR, she had a predominantly chronic cholestatic disease. Fluctuation course of symptoms and transaminases are known in PSC. Alphos was more than 2 times, which is suggestive of cholestatic etiology. And the pruned reappearance on ERCP suggested a PSC-like illness. This is an algorithm for overlap syndrome. Even a patient with AIH, PBC, or PSC, we have certain atypical features like atypical hepatic or cholestatic findings on histology or biochemistry. Even if it has a disease which is refractory to conventional treatment, then we should get a cholangiogram. If cholangiogram is normal and AMA is positive, then she probably has, if cholangiogram is normal and AMA is positive, she probably has AIH PBC overlap. If cholangiogram is negative and AMA is also negative, then the patient might have an AIH indeterminate cholestasis, which includes AIH overlap with AMA negative PBC or a small duct PSC. However, if the cholangiogram is positive and AMA is positive, the patient might have a PBC PSC overlap, which is very rare, less than 1%. And like in our case, if the imaging is positive and AMA is negative, then the patient can have an AH PSC overlap. Points in favor of an overlap in our patient was that the abnormal ERCP was suggestive of a long-standing PSC. Transaminases were more than 10 times. Ductal changes are seen in only 10% of patient in pure AIH. Alphos was more than 2 times upper limit of normal. The patient seems to have a better prognosis, which is much better than a patient than of a patient with PSC. And she did had some responses to UDCA earlier. However, points against the diagnosis of overlap in patient was that there was no history or colonoscopy was also normal, and 80% of the patients with PSC do have features of IBD. She did not have any fatigue, cholangitis, or CLD in all these years, and she had a good response to steroid, which is also a factor against an overlap because these patients tend to respond poorly to steroid as compared to a pure AIH pathology. So, how to diagnose a patient with overlap? Firstly, we have to diagnose AIH, and then we have to see if the patient has overlapping symptoms of PSC. The diagnostic criteria for AIH is a simplified diagnostic criteria which gives source for presence of autoantibodies, a level of IgG, absence of viral hepatitis, and liver histology. A score of more than or equal to 6 is probably AIH, and a score of more than equal to more than 7 was definite AIH. And if such patient has PSC symptoms, PSC cholangiography like multifocal bile duct stricture, other features of PSC, then we can diagnose an AIH PSC overlap. Now, this is the Amsterdam criteria for cholangiographic classification of PSC by ERCP, in which the various defects are in the intra and extrahepatic ducts are graded accordingly. In the intrahepatic, grade 1 is multiple stricture with normal caliber, grade 2 is multiple stricture with dilatation and decreased arborization, and grade 3 is visualization of the central branches and with diffuse severe pruning. In the extrahepatic duct, grade 1 is slight irregularities of ductal contour, however, there should be no stricture. Grade 2 is segmental stricture, and grade 3 is stricture of almost the entire length of the duct, and grade 4 is extremely irregular margin and or a diverticulum like outpouching. It is seen that involvement of both an extra and intrahepatic duct is in 75% of the patients. Only intrahepatic duct is involved in 15 to 20% of patients with PSC, and extrahepatic involved in only extrahepatic is involved in 5 to 9% of the patient. And in a study by Elizalde et al., in their patients with PSC, when they did cholangiogram, they saw that the most common extrahepatic involvement was type 3, that is a stricture of almost the entire length. And the most common intrahepatic involvement of PSC was type 2, that is multiple strictures with saccular dilatation. In our patient, had probably type 3, in which there was diffuse severe pruning. A patient also had a negative seroantibody, so we reviewed the literature if the seronegative patient behaves any differently from a seropositive patient. So, in this study from China, Bang et al., in their cohort of patients with autoimmune hepatitis, they noted that 10.2% patients were seronegative autoimmune hepatitis. Clinical characteristics and biochemical examination were, however, same between the two groups, but serum IgG levels were significantly lower in seronegative AIH patients. There was no significant difference in terms of histological inflammatory grades between the two groups. However, seronegative auto AIH patients tend to have an advanced histological grade, suggesting that it takes a longer time to diagnose such patients. With respect to treatment response, both groups had similar biochemical remission rate, and they both have similar prognosis after corticosteroid therapy. Now, the diagnostic scores, which we discussed earlier, the simplified diagnostic scores and comprehensive the diagnostic score, which is available for diagnosis of autoimmune hepatitis, are they valid for a case of overlap? Kazaza et al., in his review, stated that the comprehensive and simplified diagnostic scoring systems for AIH are not discriminative diagnostic indices, and they cannot be used to define a cholestatic AIH or imply the presence of autoimmune hepatitis in a predominantly cholestatic liver disease. So, when a diagnosis of AIH-PSC overlap is suspected clinically, key diagnostic tools are MRCP and liver histology, and a final decision can only be made as a composite score of these results, irrespective of the diagnostic score. A second differential was classical PSC. The points in favor of PSC was that she had fluctuating course of symptoms and transaminases, which are known in PSC. She had a chronic cholestatic disease, and the preliminary appearance was suggestive of PSC. However, points against diagnosis of PSC was that she had rapid resolution of jaundice, which is with steroids, which is not known in PSC. Transaminases were more than 10 times, which is not known in PSC, and she didn't have IBD, cholangitis, CLD. Now, most probably a patient had a large duct PSC according to the cholangiographic evidence we have. So, small duct PSC involves the septal and the interlobular bile duct, whereas the large duct PSC involves the segmental duct, hepatic duct, and then beyond. For small duct PSC, cholangiogram is not a good modality. We cannot visualize them, so biopsy is required. For large duct PSC, we can visualize them on cholangiogram. Incidence of small duct PSC is 9% in Western literature, but in India, it is seen in 33% of the patients. Large duct PSC is the majority of the PSC patients. We also reviewed literature whether there is a difference between small duct and large duct PSC, which we noted that Crohn's was more common in small duct PSC as compared to large duct. Jaundice and weight loss was more common in large duct. Small duct PSC tends to have a more favorable long-term prognosis in terms of death and liver transplantation. There's negligible or no risk of cholangiocarcinoma in small duct, but there's 11% incidence of cholangiocarcinoma in large duct. 23% of patients with small duct PSC tend to progress to large duct PSC, and they tend to have poorer prognosis after that. There's no role of UDC in small duct, but some benefit is there in large duct PSC. Now, other sclerosing cholangitis, which have a drastic response to steroid, could be a sarcoid cholangiopathy or an IgG4 related disorder. Points in favor of a sarcoid-like illness was that hepatic involvement was seen in around 80% of the patient in postmortem studies. Usually, the disease is a cholestatic pattern. Pruning of IHB, intrahepatic bile ducts, is noted in a sarcoid patient in few case reports. Sarcoid responds to steroid and UDCA, and spontaneous resolution has been known in sarcoidosis. However, points against the diagnosis of sarcoidosis are she has been suffering for 8 years and she doesn't seem to have any systemic manifestation, where 90% people do present with pulmonary symptoms. Transaminases are less than 3 times in sarcoid, but in our patients, they were more than 10 times. And only 15% of patients with hepatic involvement in sarcoidosis are symptomatic, and that with jaundice and pruritus are seen in only less than 5% of the patients. And such frequent relapses, which were seen in our patient, are not known in sarcoidosis. So, is IgG4 the culprit? it seems unlikely because the median age of an IgG4 related disorder is around 60 years. Male to female ratio is 4:1. And although spontaneous remissions are reported in IgG4 related disorder, but such frequent relapses are not seen. She had an 8-year history, but she has no previous episodes of jaundice or cholangitis. 90% of patients with IgG4 related disorder present with autoimmune pancreatitis, and only 10% have isolated IgG4 related sclerosing cholangitis. Also on imaging, there was no evidence of extrahepatic bile duct stricture or wall thickening, and pancreas was normal, and a prune tree appearance is suggestive of PSC. This figure shows the cholangiographic difference between a PSC and IgG4 related disorder. A short band-like stricture with beaded appearance and a prune tree appearance, along with diverticulum-like outpouching, are suggestive of PSC, whereas a long segmental stricture with pre-stenotic dilatation and involvement of lower end of CBD are suggestive of an IgG4 related sclerosing cholangitis. Now we have HISORT and the Japanese criteria for diagnosis of IgG4 related sclerosing cholangitis, which includes histology of bile duct, imaging, serology, and other organ involvement. The Japanese criteria uses the same diagnostic indices and delineates the patient into a definitive diagnosis, probable diagnosis, or possible diagnosis. So, is it all an idiopathic etiology? Like seen in idiopathic adulthood ductopenia, it is a rare chronic small duct cholestatic biliary disease of unknown etiology, characterized by loss of interlobular bile ducts. And since its initial description by Ludwig and colleagues in 1988, less than 100 cases have been reported. Symptoms and presentation of IAD can be non-specific, and it continues to be a diagnosis of exclusion. For diagnosis, the patient must be an adult or at least an adolescent. There should be biochemical evidence of cholestatic liver disease and biopsy evidence of ductopenia. Biopsy should show ductopenia, that is, absence of bile ducts in at least 50% of the portal tracts, and at least 20 portal tracts needs to be examined, and there should be no identifiable cause of cholestasis. Presentation of IID could be asymptomatic or with cholestatic pattern symptoms, including jaundice, pruritus, and fatigue. One third may present with episodic jaundice and pruritus, like our patient. And the median age of diagnosis was 27 years, and male to female ratio is 2:1. There are two distinct causes of this disease.
Akshay, you need to wind up your presentation.
Yes, sir, only a few slides. There are two.
We need to have 5 minutes for the discussion.
Yes, sir.
And we need to close at 7 o'clock.
Yes, sir. There are two types, type 1 and type 2. Type 2 is a benign pathology in which less than 50% of bile ducts are involved. Type 2 has widespread dystropenia and advances to rapidly advances to biliary cirrhosis. Diagnosis is of exclusion. We have to rule out other causes. LFT is of a cholestatic pattern. Alphas and GGT are more than 3 times. Bilirubin may be normal, and transaminase may rise to more than 10 times upper, which is 10 times upper limit of normal, which was seen in our patient.
Rush through.
So, I will rush to this algorithm. After in a patient, this is an algorithm of intrahepatic cholestasis. After excluding extrahepatic cause of cholestasis, if the patient has AMA positive, then she probably has PBC. If not, then we do her cholangiogram. If cholangiogram is abnormal, then she may have a large duct pathology. If cholangiogram is normal, then she has a small duct pathology for which a biopsy is to be done. If in biopsy it shows a PBC-like histology, then it is AMA negative PBC. And if it also has features of autoimmune hepatitis, then or possibly an overlap syndrome may be present. If there's histology suggestive of PSC, then she has isolated small duct. And if AIH is also present, then also she has an overlap-like syndrome. And if there's only ductopenia and no IBD, then she might have idiopathic adulthood ductopenia. If there's granulomatous involvement, then there could be sarcoidosis. So this was the plan for our patient if and whenever she reports back to us. So then there were some practical issues in the patient. First, is the renal disease related to her present liver illness? And we had a discussion with our nephrology unit, and they were of the opinion that the two illnesses were separate. Secondly, is the last relapse part of the same illness which she has been having since last several years? Well, the presentation was of a cholestatic hepatitis, and the R factor was also 3.9. So we had an interdepartmental discussion, after which we decided to treat the present relapse as a part of the previous illness. So next issue was whether how to treat her without a definitive diagnosis. UDCA was relatively safe, so we put her on UDCA. Giving her steroids without a definitive diagnosis would be difficult to justify. But the main question was what happens when she relapses next and then again refuse to do a biopsy. Should we give steroids or not is a matter of widespread debate. Thank you.
Akshay, there are some questions. Want to take it? Akshay, are you getting me?
Yes,
So
sir.
there are two questions which I can see. The role of obitocolic acid. Is there any role for obitocolic acid in PSC?
No, sir. The role of obeticholic acid is much more defined in PVC, not in PSC, sir.
And the other question is that does symptomatic PSC have relapsing course and remain stable course for 8 years?
So I couldn't get your question, sir.
So is the whole picture for last 8 years? Does it go with PSC natural history?
Sir, spontaneous fluctuations and remissions are known in PSC, but classical PSC doesn't seem to present like that. She doesn't have any involved. She doesn't have cholangitis, no features of CLD. She didn't had any fatigue, no other symptoms except recurrent episodes of cholestasis.
What is the main reason why she is refusing the biopsy?
So, maybe because of financial constraints, financial and she has her apprehensions regarding undergoing a liver biopsy. Sir. So maybe whenever next time she comes to us, we will try to convince her again to undergo a liver biopsy.
I don't know how much Anurag charges for the liver biopsy, but liver biopsy is not a very costly procedure. Anurag?
So this is the first time that she came to us and she mentioned she had failed investigation. So I think they ran out of money before we suggested a biopsy. And reasonably certain we were able to convince her. But the problem I wanted to discuss here was that there is this difficult clinical patient and someone refusing a biopsy. And what do you do with this kind of a patient? I mean, that's a practical problem. She just might refuse it again. So our unit decision was to actually, if she comes with cholestasis again, if she refuses biopsy again, then give her steroids, and then if she responds drastically the way she did last time, then to empirically continue steroids and not stop them. So that's a
Could it be BRIC? Benign recurrent rapid cholestasis.
pruning of intrahepatic cells. I mean, that's not seen in BRIC, and the OTPT went very high in the last episode. Again, that would not happen with BRIC. So BRIC we did think of only on history, but after investing. Yes, Dinesh, what do you have to say?
It was always high.
Yeah, that's true.
So it almost rules out the break. And then, hello.
Dinesh, you need to be louder.
Sir, her GGT was always high on three occasions. So initial clinical diagnosis was break only, but when we reviewed the her old reports, her GGT was quite high.
So, any prediction about the natural history of this overlap syndrome? What do you think about the lapses in this particular type of overlap syndrome?
Hello. Hello.
What do you think of the natural history? Can you hear me? What do you think could be the
I'm not getting your question. Hello.
Can you hear me now? What is the natural history of this overlap syndrome?
So this overlap syndrome is usually, I believe that by 8 years of now, he should have some kind of serotic changes which is not happening in this patient. Her ultrasound is normal, her flow time is normal, everything is fine, excepting that she comes in every year or two with cholestasis features. So it's not fitting classically into it. The possibility of a biopsy which would give most of the answers to us, and we are not getting it. So that's
All right. Any final comment from Anurag or Dinesh before we close up?
No, so I think we've discussed it all, and